We will now watch a few scenarios of de-escalation. In each of these cases, you will see some good verbal de-escalation and also some opportunities to improve. Our objective for this chapter is to give you more practice with the elements of verbal de-escalation.
In this first case, we will meet a patient who is in pain and requesting pain medication. However, the team is concerned that the patient may have a serious opiate use disorder and is inappropriately asking for opiates. Let's see how this clinician handles the situation.
Hi, Violet.
Hi, doctor.
My name's Chelsea.
I need some more pain medications. I'm in a lot of pain.
Tell me a little bit about your
Please,
pain.
No one's listening to me. I'm in a lot of pain. I need something strong, something like hydrocodone.
You know,
or
I
something
actually
like
can't
that.
offer you any opiates
No,
right
what?
now.
No! Oh my God, I can't believe what I'm hearing. Oh my God, nobody's listening to me. You're just like the rest of them. You are just like the rest of them.
We can agree to disagree with
No.
you. I'm not able to offer any opiates
Oh,
at
I
this
can't
time.
believe this. I can't believe what
However,
you're saying.
I would
oh
like
my God.
to hear some other options.
You don't care,
Give you some other options.
You don't care. I'm in pain here, and you don't care at all.
You know, I'd like to offer you some alternatives. Why don't we try some gentle stretching or a hot pack? I can give you a hot pack, and then we can try in the next 15 minutes to reassess and see how you're doing.
Okay, fine, whatever.
Several things about this case went well. First, you saw the clinician immediately assess the patient's degree of agitation and maintain a safe personal space, both for the patient and herself. The clinician wasn't provocative and immediately began actively listening to what was happening.
Things became more difficult when the patient was not getting what she wanted. You saw the patient speak more loudly and appear more agitated. The clinician did a good job responding by finding common ground with which to agree with the patient.
You might not be able to agree on everything with the patient. Here, the patient continued to insist on opioid medications. You may agree she's in pain and needs treatment. You may not agree that opioids are indicated. Chelsea used a favorite phrase of ours, "We have to agree to disagree." She repeated it several times in a concise way, and in so doing set clear limits for the patient. This was the strategy that let her move on to offer the patient additional choices for pain control and ultimately achieve a successful de-escalation.
Remember that these techniques work regardless of the patient's diagnosis. This patient may be agitated because of increased pain or anxiety, but she also might feel uncomfortable because of other medications she received, or she might be in opiate withdrawal. Once the patient has been de-escalated, you will want to continue with assessment and treatment.
In this next case, we'll see Dr. Seefeld approach a patient with suicidal ideation.
I hate you! I'm gonna just kill myself.
Tracy?
What?
Hi, I'm Dr. Seefeld. How are you doing?
I'm just really frustrated, okay?
Yeah, it sounds like you're going through a really tough time. I'm sorry to hear
He's gonna
that.
break up with me. I need to leave. I need to leave so I can go talk to him.
Yeah, I know. I'm sorry. We do have to have you stay a little bit because you did tell us you're suicidal, so we do have to have a provider do a comprehensive...
No, I don't want to do any of that, okay? I just want to go, okay? That's gonna take like way too much time. I need to go.
We want to help you get out of here as soon as we can. We do have to have a person come in and talk to you a little bit more, but in the meantime, can I get you anything to make you more comfortable right now? Would you like some water or a blanket? Maybe someone to sit with you?
A blanket?
Okay, I'll be right back with that blanket.
This patient is pretty labile. Fortunately, this de-escalation went well. The clinician maintained safe personal space and was not provocative.
I also like that Dr. Seefeld didn't engage the patient in more discussion about her suicidal statements. Clearly, a comprehensive safety assessment is going to be important, but not right now. The goal in this interaction is to help the patient regain control of her distress and behaviors.
We need to come back to the final element of verbal de-escalation, debrief the patient and staff. Let's watch Dr. Seefeld debrief with this patient after she has calmed down.
Tracy?
Yeah.
It's Dr. Seefeld again. Do you mind if I talk to you for a couple minutes?
Yeah.
Okay. Do you mind if I pull up a chair? Okay. How are you feeling now?
A lot better.
I'm glad to hear that. You were really distressed before.
It's just really frustrating. Like we get in these arguments and I get really overwhelmed.
Yeah, that can be a really hard situation. So I wanted to ask, if you do start feeling frustrated or overwhelmed again, what are the things that we can do that would be most helpful to you to feel better?
Just talking to someone. Like someone who will listen.
Yeah.
This blanket helped.
Great. Anything else?
Probably some water.
Okay, awesome.
Yeah.
Do you mind if I write those on the board, just to keep them in mind?
Yeah.
Okay.
This was a good debrief. The clinician and patient agreed on what happened and did some brief problem solving for how to avoid a similar episode in the future.
Debriefing is also helpful to the clinician. De-escalation can be stressful and difficult. Even under the best of circumstances, it does not always go well. Let's talk with Dr. Seefeld about her experience.
So Trina, we just watched you de-escalate an agitated patient. Are you okay?
I'm doing all right, thank you.
Good. What do you think happened?
Well, I mean, she started out, she was having an argument with her boyfriend on the phone, and it sounds like her boyfriend threatened to break up with her, which obviously made her very upset. And so I was walking into that and trying to help her calm down and also be okay with remaining in the room until we could have a provider do the safety assessment for her. So.
Okay. What do you think went well?
I think she responded pretty well to when I offered, you know, like a blanket or water, things, the comfort care. I think she was able to respond to that.
Yeah, it seemed like it. What do you think could have gone better?
I think I got a little too wordy with her when I talked about how she couldn't leave until we did the safety assessment. It was probably too much psychobabble for her at that point.
Yeah. And yeah, I think all of that is right. And again, at the end of a de-escalation, it's important that we debrief not only with the patient, but also with the provider.
In the next chapter, we will introduce some more complicated de-escalation scenarios.